So, welcome, guys. Let's talk about sickle cell disease, that is anemia. So, it's a chronic hemolytic anemia which is characterized by sickle shaped red blood cells as a result of homozygous inheritance of the hemoglobins. So, in hemoglobins, amino acids valine is substituted with glutamic acid in the position of 6 of the B chan. So, this HB polymerizes at sites of low partial pressures of oxygen, and red blood cells assume the sickle shape. So such cells adhere to vascular endothelium and plug small capillaries and arterioles, leading to occlusion and infraction. So because the sickle red blood cells are fragile and cannot withstand the trauma of circulation, so hemolysis occurs in the small blood vessels. So these abnormal red blood cells are also destroyed within the spleen. So the clinical features include impaired growth and development, susceptibility to infections, that is malaria, influenza, and pneumococcal. So anemia and mild jaundice, hepatosplenomegaly in children, bone pain, especially long bones in children, pain and swelling of the hands and feet, that is and foot syndrome, arthralgia with fever may occur, a vascular necrosis of the femoral head is common, severe abdominal pain with vomiting, occlusion of major intracranial vessels may lead to hemiplegia, cranial nerve pulses, and other neurological deficits. Acute chest syndrome, that is sudden onset of fever, chest pain, leukocytosis, and pulmonary infiltration on an X-ray is visible, which may be fatal. There's also tower shaping, that is bossing of the skull. So investigations include full hemogram to include peripheral smear and HB levels. Sickling's test should be done. HB electrophoresis. An X-ray of the long bones is going to show cortisol thinning noted with the irregular bone densities and new bone formation. For the skull bone widening of the Doppler space, we manage this by transfusion for severe anemia, that is a plastic crisis, and in cases of infection. So for sickle cell crisis, there are three types, that is thrombotic, aplastic, and hemolytic. So we manage this crisis by giving oral fluids until they produce dilute urine. We give analgesics regularly in acute phases, or if pain is severe, we give narcotics and analgesics such as morphine injections, 10 milligrams when necessary. We treat infections vigorously and promptly if present by use of ceftriaxone 1 gram IV once daily for 7 days, or comoxiclav 1.25 8 hourly for 7 days. We also treat malaria if present in endemic areas where the condition is common. We give supplementary folic acids, but we avoid iron in these cases. Blood transfusion is also very necessary, so blood must be given immediately at the time of need, and we reevaluate our patients immediately prior to transfusion and ensure that blood is still required to save life. So we use only blood if it's free of HIV and has been properly grouped and cross-matched, and it is in correct bag labeling for the patient. We remove the bag of the blood from the blood bank, refrigerated just before transfusion. We never give transfused blood that has been out of refrigerator more than an hour or out of the donor for more than 21 days. We also give furosemide 1 milligrams per kg start IV at the beginning of the transfusion, but only if the patient is not actively bleeding. So if the patient has heart failure, we also give furosemide immediately and do not wait until blood is available. So we give antimalarial drugs full course to all patients having blood transfusion on malaria endemic areas. We also transfuse adults who require a minimum of 2 units of blood. Transfusion only 1 unit in an adult probably not needing. So management of a transfusion reaction. What are we supposed to do when we notice a transfusion reaction? We'll notice a transfusion reaction when the patient develops fever, skin rash, or the patient becomes ill. At that point, we stop the blood transfusion immediately. We give chlorophenamine, 5 milligrams IV start or 5 milligrams IM start. We return blood to the bank with a fresh sample of the patient's blood and we monitor urine output. So we also monitor cardiovascular and renal function. If hypertension develops, we start IV fluids. So hydroxyurea should be given to patients with more than 3 crises per year. So this can be started at a dose of 10 milligrams per kg orally and escalated to 5 milligrams per kg to a maximum dose of 25 milligrams per kg per day. Thank you very much. I hope you can be able to take question about sickle cell anemia and we can be able to manage our patients promptly in case of a blood reaction. Thank you.